Good afternoon, everyone. My name is Ioana Angurano, and I'm the Community Health and Prevention Analyst at ASTO. I'm honored to welcome you to this webinar on behalf of the CDC and to be joined by Suzanne Hurley, the Dissemination Team Lead at the CDC for the Prevention Research Centers Program, known as the PRC program. Today we will highlight research PRCs have developed to reduce health disparities by increasing access to healthy foods in low-income communities. Suzanne?
Hi, everyone. This webinar is the second of a three-part series highlighting research and tools developed by PRCs and their related thematic networks. We'd like to thank ASTO for showcasing the work of the PRCs and for organizing these webinars.
The PRC program consists of 26 public health universities or schools of medicine that conduct community-engaged research. Each PRC designs, evaluates, and implements a health promotion and disease prevention program that reduces health disparities. Today we will highlight nutrition research developed at the Case Western Reserve University PRC. In addition, PRC centers collaborate within 7 thematic research networks on specific research topics. The Nutrition and Obesity Policy Research and Evaluation Network, known as NOPRIN, conducts nutrition policy research. NOPRIN identifies and evaluates nutrition policies that increase access to healthy foods in schools, work sites, and community settings. And the second presentation today will highlight NOPRIN research and tools. As will be featured during the webinar, PRCs and NOPRIN engage community stakeholders and public health departments in the implementation of programs. In addition, PRCs offer technical assistance to public health agencies through policy evaluation and program development. Our goals for this webinar are to describe how PRCs and other affiliated partners within NOPRIN evaluate effective nutrition policies, highlight how state health departments can partner with PRCs to improve access to nutrition in low-income and low-access communities, and to provide ideas for working with community partners to reduce health disparities. Before we get started, I would like to provide an overview of the logistics for this afternoon's webinar. This webinar is currently being recorded, and a link will be provided by email. Following each presentation, participants will have the opportunity to ask presenters questions, and we invite you to participate by typing your questions into the on-screen chat box at any time during the webinar. In addition, if you are having technical difficulties, please let us know through chat. Our first presenters are Dr. Darcy Friedman and Ashley Davis, who will present on a partnership between the Case Western Reserve University, PRC, and the Ohio Department of Health focused on improving statewide access to healthy foods. Dr. Darcy Friedman is the Associate Professor of Population and Quantitative Health Sciences and Social Work at Case Western Reserve University. She's the Associate Director of the CDC-funded Prevention Research Center for Healthy Neighborhoods. Dr. Friedman's research examines the influence of community food environments on health and well-being with an emphasis on strategies to promote health equity. Dr. Friedman received the 2016 Saria Samuels Memorial Award by the American Public Health Association Food and Nutrition Section, recognizing her outstanding contributions to advocacy, policy, evaluation for public health nutrition. Ashley Davis is the manager of the Creating Healthy Communities program at the Ohio Department of Health. Ms. Davis leads the primary prevention activities in the Bureau of Health Promotion within the Office of the Medical Director, where she manages healthy eating and active living activities within 3 CDC-funded grant programs for the state of Ohio. She's a registered dietitian with a master's in wellness management. Ms. Davis also participates on multiple state-level collaborations, including the State Health Improvement Planning Committee, and is the chair-elect for the Fruit and Vegetable Council for the Association of State Public Health Nutritionists.
Thank you, Suzanne and Ioana, for inviting us to take part in today's webinar. During our portion of the presentation, Ashley Davis and I will be speaking about our organizations and the ways we collaborate around nutrition-related chronic disease prevention, research, and evaluation. We will start off by highlighting examples of existing collaborations between the Prevention Research Center for Healthy Neighborhoods, or PRCHN, and state and local health departments. Then we will give 2 examples of current collaborations focused on increasing implementation of nutrition-related policy, systems, and environmental interventions. Ashley and I work very closely on these two projects, including the Building Capacity for Obesity Prevention study and the Ohio Nutrition Incentive Network. We plan to have at least 5 minutes for questions and answers before turning the presentation over to Dr. Seligman. So please feel free to type in questions as we are presenting. The Prevention Research Center for Healthy Neighborhoods, where I am located, was established in 2009 as a CDC-funded prevention research center. The PRCHN is housed at Case Western Reserve University School of Medicine in Cleveland, Ohio, which is located in the northeastern region of Ohio. We are the only PRC in the state. We are one of 26 CDC-funded PRCs, and our mission is to foster partnerships for developing, testing, and implementing strategies to prevent and reduce the burden of chronic disease. The PRCHN has 5 main areas of research with many topics straddling multiple domains. Today, I will focus on our nutrition-related research that addresses 4 of our 5 domains, including food access and community nutrition, supportive environments for healthy eating and active living, place-based environmental surveillance, and chronic disease management. Tobacco use prevention and cessation is another major area of research in the PRCHN. However, given the focus of this webinar today, I will not be talking about this domain. The PRCHN is an affiliated member of the CDC-funded Nutrition and Obesity Policy Research and Evaluation Network, or NOPRN, through our core research, which is called FreshLink, that seeks to improve farmers' market reach, adoption, and impact among people receiving food assistance benefits, and through our Building Capacity for Obesity Prevention study that I'll be talking about today. As this slide highlights, much of the research conducted by the PRCHN involves partnerships with state and local health departments. These include partnerships on county-wide collective impact projects such as the Health Improvement Plan Cuyahoga County, or HIPC for short, and on surveillance such as collaborations with several health departments to collect local data using the CDC's Behavioral Risk Factor Surveillance System and the Youth Risk Behavior Survey. You can learn more about these partnerships and example reports emerging from the various surveillance data collection on our website at prchn.org. As you can see, the PRCHN has a number of collaborations with health departments specifically focused on nutrition. These include collaborations aimed at implementation and evaluation of food environment interventions, such as produce prescriptions tailored to new moms and to people with hypertension, nutrition incentive programs to reduce the cost of purchasing fresh fruits and vegetables, and healthy food retail initiatives branded as Good Food Here programs throughout Ohio. Our partnerships utilize different models to promote change, including community health workers and cross-sector collaborations. In addition to our PRC funding, these collaborations are supported by grants such as the CDC REACH program and the U.S. Department of Agriculture Food Insecurity Nutrition Incentive Program, or the FINI program for short. Given time constraints, I'm going to focus on one of these collaborations, the Building Capacity for Obesity Prevention study, or BCOP. Before diving deeper to the BCOP collaboration, Ashley will elaborate on mutually beneficial opportunities for health departments to collaborate with PRCs.
All right, thank you, Darcy, and thank you for having me. Okay, so as many of you are maybe familiar with the core functions of public health, as stated in the IOM report, the 3 core functions of public health are assessment, policy development, and assurance. Public health's purpose is to address and prevent epidemics such as obesity and chronic disease burden, and to promote and encourage healthy behaviors. The public health wheel shows that the 3 core functions, assessment, policy development, and insurance, in black around the wheel, of essential services. In essence, the essential services can be grouped under the 3 core functions. The 10 essential public health services describe the public health activities that all communities should undertake. Public health systems should monitor health status to identify and solve community health problems, diagnose and investigate health problems and health hazards in the community, inform, educate, and empower people about health issues, mobilize community partnerships and actions to identify and solve health problems, and so on and so forth. Partnership with a PRC can be mutually beneficial and reinforcing at many points within these 10 essential core public health functions. I particularly find most relevance with the assessment, research, and evaluation aspects of the model. Applying access to healthy foods as a topic, the same core functions apply. Strategies, as Darcy previously mentioned, such as healthy food retail, farmers markets, and breastfeeding support have shown effectiveness on increasing consumption of fruits and vegetables. These strategies deploy a systematic and environmental impact on health, which is not a new concept. In fact, much of the success of public health in the 20th century came through enacting policies, changing systems, and creating environments that support health. For example, addressing environmental factors such as unsafe roads and poor sanitation have led to improvements in both the injury prevention and infectious disease fields. However, the rising burden of preventable disease is precipitating a renewed effort within public health to approach health promotion by addressing these external influences and their impact on health and health behaviors. We will discuss 2 examples of addressing policy systems and environmental changes within the healthy eating sector now.
All right, thank you, Ashley. The Building Capacity for Obesity Prevention uses a collaborative researcher-practitioner partnership approach to guide our research. The 3 primary partners include the PRCHN at Case Western Reserve University, the Ohio State University Supplemental Nutrition Assistance Program Education, also called SNAP-Ed, and the Ohio Department of Health Creating Healthy Communities Program, or CHC, which operates at local health departments, and Ashley will talk more about CHC in a minute. Both SNAP-Ed and CHC have on-the-ground staff working in counties across Ohio with the goal of improving nutrition through policy, systems, and environmental approaches. I'll use the term PSE throughout this presentation to refer to these types of approaches. Our goal is to identify key aspects of community readiness and practitioner capacity influencing successful implementation of 4 nutrition-related PSEs. Many of us are familiar with the Public Health Impact Pyramid developed by Dr. Frieden, the former director of the CDC. This model provides a framework for thinking about the role of PSE interventions to achieve public health goals. PSE interventions align with the portion of the pyramid focused on changing context to make the healthy choice the easy choice. Research demonstrates that PSE interventions such as water fluoridation and tobacco taxes result in large-scale impacts without requiring individuals to make substantial behavioral changes. The 4 PSEs we focus on in BCOP include farmers markets, healthy eating policies and childcare, healthy food retail, and farm to school. All 4 represent interventions recommended by CDC and USDA as evidence-based approaches for improving nutrition as a part of a broader strategy to obesity prevention. Farmers market interventions include, for instance, increasing SNAP payment options and/or establishing nutrition incentive programs. Healthy eating policies include Healthy eating policies and childcare include approaches to making breastfeeding an option and/or establishing standards for menu planning. Healthy food retail interventions include healthy checkout lanes or stocking healthy options in corner stores. And farm-to-school interventions include salad bar programs or integration of school gardens into academic programming. Despite the fact that nutrition-related PRCs are being recommended, many communities relate to this cartoon. We know we should be doing PRCs and we hear about the results they can achieve. However, we are not sure what steps are involved to achieve these goals. In other words, there is a big black box where the miracle happens. Even though there are many toolkits available describing different PRCs, few are tailored to meet communities where they are based on current levels of community readiness and capacity. This is precisely the research goal of BCOP, to create tools to optimize implementation of nutrition-related PRCs to promote healthy eating and reduce obesity trends, particularly in low-income communities where healthy food access tends to be more limited. To create these tools, our team used a mixed methods consensus modeling approach to align the tools with perceptions about which factors are most important to successful PRC implementation. Data collection included CHC and SNAP-Ed staff from 9 counties in Ohio, highlighted in red on the map. These counties represented diversity in geographic region, with 5 counties designated as primarily urban and 4 as primarily rural. All counties had high rates of obesity and high rates of federal food assistance recipients. Within each county, we also conducted focus groups with intended users of PRCs, including SNAP and SNAP-eligible populations and members of community coalitions organized by the local health departments. These coalitions included leaders from schools, community-based organizations, and other engaged community stakeholders. In all, we conducted 18 in-depth interviews and 23 focus groups, engaging nearly 200 community stakeholders in the qualitative research process. Data were then coded by our team at the PRCHN, and experts in each of the 4 PRCs were invited to participate in a consensus conference to prioritize factors influencing successful PRC implementation. We held a different consensus conference for each of our 4 PRCs, and this picture here you can see is some of the activity going on in that consensus conference. The result of this process is the development of web-based tools that can be used by SNAP-Ed and CHC practitioners throughout Ohio to tailor implementation of nutrition-related PRC interventions. This slide shows you the homepage of our website that will go live in summer 2017. We call the tools on our websites PRC Readies, which stands for PRC Readiness Assessment and Diagnostic Instruments. We will launch 4 PRC Readies focused on farmers market, farm to school, healthy food retail, and healthy eating policies and child care. Each PRC Ready includes intervention-specific questions to assess different aspects of readiness and capacity. The assessments have an average of 25 questions that are answered using a Likert response option as noted on the slide. 2 example questions are listed here. The first is related to organizational capacity for farmers markets, and this question states, to what extent does your organizational or program budget have sufficient funds to support farmers market PRC projects this year? And the second question is related to child care center capacity, and it states, to what extent is there parent buy-in and support for healthy eating PRC projects in child care centers or preschools in your service area? Again, the themes and related indicators were derived from qualitative data we collected from stakeholders throughout the state. The PRC Readies can be taken individually or as a group, and a weighted scoring algorithm is used to identify 3 recommendations to guide planning and local action. We focused on creating recommendations resulting from the assessments rather than scores based on feedback from community nutrition and public health practitioners who consistently shared interest in getting information about what to do next rather than feeling like they were being graded or examined through the assessment. The recommendations are tailored to 3 stages of readiness. The getting started stage reflects the earliest level of engagement. Developing and growing stage reflects communities that have already started to implement a PRC, and the sustaining and expanding stage is geared to communities that have experience with PSCs and are looking to extend their work. Importantly, a community could be at a different stage for each PSC. Moreover, a practitioner who worked in one community may find their readiness score is quite different in a new community that has different resources and different assets. On this slide here, you can see just the very small portion of 3 example recommendations, and a practitioner would then have links to resources to guide their practice. In pilot testing of the PSC readies in different counties in Ohio, we found that each practitioner received different recommendations for planning and action in their targeted communities. This aligns with our expectations that no 2 communities are in the same place in terms of readiness and capacity. The PSC Ready seeks to tailor PSC implementation to the reality of each community. Before I wrap up, let me share a few next steps for BCOP. Our plan is to conduct usability assessments of the web-based PSC Readies in 2017 with the goal of refining the tools and web experience to support statewide dissemination in 2018. We hope the tool is used in at least 60% of the 88 counties in Ohio in 2018, allowing for validity and reliability assessment of the tools, as well as analysis of trends of readiness and capacity by region and by PSC. And we're beginning to engage in discussions with other states about the possibility of making the PSC Ready available for practitioners beyond Ohio.
Okay, and I'm going to talk a little bit about the Ohio Nutrition Incentive Network and some work that we have been collaborating with the PRC on. But first, to start off, I'm going to give an overview of the program that I manage at Ohio Department of Health called Creating Healthy Communities. And Darcy spoke a little bit about the involvement within the BCOP program. We know that chronic diseases such as heart disease, stroke, diabetes, and many cancers are among the most common, costly, and preventable of all health problems in both the United States and Ohio, and are associated with reduced quality of life, poor health outcomes, increased healthcare needs, and higher healthcare spending. Death due to chronic disease represents a significant burden among Ohioans. While all Ohioans are at risk for developing a chronic disease, rates of heart disease, diabetes, stroke in Ohio are higher among residents of Appalachian, rural counties, and those of minorities. The program I manage is called Creating Healthy Communities with the goal to prevent and reduce the burden of chronic disease in Ohio. We fund 23 local counties to implement evidence-based strategies within high priority communities. 22 of the 23 of these local grants are housed within the Public Health Department. CHC implements these evidence-based strategies in high priority communities, communities with the highest need, including high chronic disease rates, high rates of poverty, low access to healthy food, etc. Today we will be focusing on this section of the presentation on our collaboration around farmers markets and retail setting for SNAP or Supplemental Nutrition Assistance Program incentives, and a specific project that we are collaborating with Case Western PRC. The diagram on the slide shows the breadth of evidence-based interventions that we are implementing across Ohio. So nutrition incentives. Nutrition incentives are alternative currency in the form of a coupon, token, or electronic voucher that can be spent on produce at farmers markets and grocery stores. A catalyst for healthy food purchases that makes it easier for low-income Americans to buy fruits and vegetables. The Ohio Nutrition Incentive Program is in the development stages and is set to launch in June at retailers, expand farmers market nutrition incentive programs, and produce prescriptions. We have contracted with Wholesome Wave to be the project lead. This project presents a clear path to reach significantly more of the 1.56 million Ohioans currently participating in SNAP. We know that the wide majority of SNAP recipients are using their cards at large retailers. This project will substantially broaden access by enabling SNAP customers to benefit from the program where they already do most of their shopping in the retail sector. Produce Perks expansion will allow more of Ohio's 320 farmers markets to offer local produce at an affordable price to SNAP shoppers, yielding a multitude of benefits to consumer health, farm viability, and local economies. Finally, the third prong approach of this program is a fruit and vegetable prescription pilot program that will begin to build evidence on the positive health impacts of nutrition incentive programs, which is key to combating the growing rates of obesity, hypertension, and diabetes, and food insecurity in this state. So as you can see on the slide, these are the key components of our statewide program. And prior to our contract launching, the Ohio Nutrition Incentive Network formed with the assistance of Wholesome Wave. Over the past year and a half, we have formed a stronger network of partners. As you can see, the network framework is listed with 7 spokes, including a retail grocery spoke, a farmers market spoke, and regional spokes, which represent farmers markets across the state. Case Western PRC and the Ohio Department of Health are cross-cutting agencies that will support the network through evaluation and resource support. Just to reiterate where we are as a state briefly, we have a high need in Ohio with low rates of fruit and vegetable consumption and high rates of food insecurity. Thus the basis of the project. This is an outline of our statewide nutrition incentive program, and included in there is the anticipated reach. To reiterate, the PRC is our project evaluation partner. And as you can see, in year 1, our anticipated reach will be 9,000 customers, in year 2, 15. Project evaluation. So a key component of this project is evaluation, where Wholesome Wave and Case Western Reserve University PRC will use the data and key findings to inform improvements to program implementation throughout the project. Of key importance will be the robust data collection up front to strengthen a potential fall 2017 FINI application. Additional components of evaluation will include behavioral changes in purchasing and consumption among program participants, which is direct to consumer and retail, effective marketing and outreach strategies, impact of incentives on retail grocery produce sales, and the potential replicability and improvements of programs at all venues, farmers markets, retailers, and produce prescriptions. So our next step as a network is to leverage additional funding and to target new partnerships to expand the program reach exponentially. We hope to expand program resources to create a consumer website, expand the network, directly target SNAP users with drive-to-market messaging, expand overall program awareness through paid media across the state, and increase our social media presence, word of mouth, and reach. So how are we making it happen? From the State Health Department perspective, a couple key important ingredients to this project include buy-in, which comes at the highest level from our State Health Improvement Plan. As a state, we just released in February our State Health Improvement Plan, and located within the plan are some of these objectives to increase farmers markets and retailers who are implementing SNAP incentive programs. We also have a state chronic disease plan that also drives priorities and resources. Some of the funding that is included to fund this project are multiple sources of Centers for Disease Control and Prevention funding, such as the Preventive Health and Health Services Block Grant, the state and local public health actions to prevent and reduce obesity, diabetes, heart disease, cancer prevention, and in addition, some state general revenue funds. And at this time, I think that Darcy and I will open it up for a couple minutes of questions.
Hi, thank you so much, Dr. Friedman and Ms. Davis, for your presentation. We do have one question at this time, and if anybody has any other questions, please type into the chat box. Is social media part of your marketing and outreach strategy? And if so, explain how.
Yes, social media is going to be a part of our outreach strategy. Within several different sectors of social media, we're going to be working within the Facebook and the Instagram settings, I believe. And in those areas, you can prioritize different demographic groups and geographic groups so that we can drive to the closest market or retailer that would be available to that SNAP user.
Okay, great. Just one more question. What recommendations do you have for public health departments who want to engage farmers markets, food retail, and schools in nutrition programs?
Yeah, so good question. So partnerships, and something that I didn't mention, but our local health departments that we fund, the 23 communities, all have a coalition, and cross-sector diverse partnerships is really the foundation and key to success of our program. So engaging the chambers of commerce, business, as well as education, nonprofit sectors is really important, not only to leverage additional funding and to support a shared goal, but to really leverage each other's skills and increase buy-in.
Okay. Just one more question that just came in. What strategies will we use to expand BCOP to other states, given that they face different barriers to implementing PSCs?
Yeah, that's a great question. As a part of our plan to expand to other states, we would begin a process in a state with a consensus expert panel meeting to make sure that there's agreement within that state that the indicators of readiness that we found in Ohio would be relevant for their state. We think that one of the goals in developing the PSC Ready here in Ohio was to be including counties that represented great diversity in terms of geographic region and also political orientation, knowing that policy system environmental interventions are influenced as much by that local sociopolitical context as a number of other factors. And so you hear the saying, so goes Ohio, so goes the rest of the nation. And so we purposefully included that diversity in our development process. So, ideally, our tools will be more relevant in other states. But, of course, we would need to do that research to confirm.
Thank you so much. And at this time, we're going to move on to our second presentation. And please feel free to continue to type in your questions in the chat box, and we will respond to them as we can. Our second speaker is Dr. Hillary Seligman, who will present on the NOPRIN project, how the NOPRIN project is evaluating how local food banks can be used to increase access to healthy foods for food-insecure populations. Hillary Seligman directs NOPRIN, is the lead scientist and senior medical advisor for Feeding America, and is an associate professor of medicine and of epidemiology and biostatistics at the University of California, San Francisco. In addition to this work, Dr. Seligman founded Eat San Francisco, a healthy fruit and vegetable voucher program for low-income residents of San Francisco. She's one of the nation's foremost experts in the health implications of food insecurity. Her expertise include federal nutrition programs, the charitable feeding systems, food affordability and access, and income-related drivers of food choice. Dr. Seligman?
Great. Thank you so much for the opportunity to present today. I will first show you my conflicts of interest slide. This is where I get funding from. I'm going to briefly introduce NOPRN, building on the information that you've heard already, and then give some background about the charitable feeding network in the United States and how my PRC-funded project fits within this charitable feeding system. And then I'll briefly talk about some ways in which local health departments can interact with their charitable feeding network in their state or region. So as you heard before, NOPRN is a thematic research network of the prevention research centers. Its goal is to foster an understanding of the effectiveness of policies to prevent childhood obesity through improved access to affordable, healthier foods and beverages across many different settings. And the way in which we do this is by doing research across multiple disciplines in policy research and evaluation along the entire continuum of policy development, which includes identifying policies, developing those policies, evaluating them, and then translating effective policies into new settings and environments. We have two strategies within NOPRN for doing this work. The first is by dividing up into working groups that have deep expertise in specific content areas that spans multiple academic disciplines. And the focus in these working groups is really on evaluating policies and then disseminating findings not only through the academic literature, but also through reports, workshops, webinars, and other ways that are more friendly towards local health department, picking up these policy evaluations and using them in their own work. My own expertise within this is within the Hunger Safety Network group. The second strategy is by the PRCs funding specific projects. You heard one of those today, and I will tell you about our project as well from the University of California, San Francisco. We also here serve as the coordinating center for the overall NOPRN thematic research network. And we bring in addition to academics across the United States who are working on policy research and development, we bring in federal advisors like from the NIH, the National Institutes of Health, and the USDA, and other partners like the Robert Wood Johnson Foundation and NCORE, so that we really are building a transdisciplinary group that has perspectives that are represented in many areas of policy evaluation and implementation. So as Juana mentioned in the beginning, if you want to learn more, please go to our website, www.noprin.org, and you can see not only all of the products that we've developed, but also our calendar of presentations. So the project that we have funded through the Prevention Research Center we call Fresh Foods, which stands for Food Banking Research to Enhance the Spread of Healthy Foods. We concentrate not just on perishable foods, but how to use the food banking system to enhance the spread of all kinds of healthy foods across the network. And to understand this, I'm going to give you a brief background on the charitable feeding system and remind people that there are 42 million people who are food insecure in America and 13 million children. So this is an enormous problem in the United States. The charitable feeding network that is organized under Feeding America includes 200 food banks that are local, regional, and state level food banks that partner with about 60,000 food pantries and meal programs to reach about 46 million Americans annually with food. This network is loosely overseen by a national organization. And essentially, the Feeding America network serves every county in the United States. There are states that have less coverage of the food banking system, but at least in theory, every county is assigned to one Feeding America food bank in the country. The national organization sits in Chicago and Washington, D.C. Feeding America's goal is that by 2025, in collaboration with their network and their partners, they will ensure access to enough nutritious food for people struggling with hunger and make meaningful progress toward ending hunger. And The way that they do that is primarily by securing donations from national and local retailers, and the national office works primarily with national retailers and food service organizations, food companies, and contracting with government agencies, and then moving food to where it is needed. That food is then stored and distributed from a food bank, and the food pantries and other meal programs then accept the food distributed from the food bank and distribute it to people who need it. So that is to reinforce to you that a food bank is not the same as a food pantry. In 95% of the country, a food bank refers to the warehouse facility where the food is sourced, stored, packed up for distribution, and then distributed to the food pantry. And the food pantry is where the food is actually distributed to people in need. There are a few areas of the country that call their food bank call their food pantry a food shelf, and then call their food bank a food pantry. So what this means in this complex system is that there are multiple different leverage points at which you can change the nutritional content of the food distributed to a client. We can enter the system at the point of the Feeding America National Organization, at the food bank, at the agency, which is generally a food pantry but maybe a food meal program, or also at the level of the client. So one example point of that leverage would be where food is sourced from. So for example, our estimates at Feeding America of how food is going to be sourced over the next 10 years includes 4.75 billion meals that will come through donations. This is the vast majority of food that comes through Feeding America. But there is some opportunity to purchase food, and then there are donations from federal programs into the charitable feeding network. So even, for example, if the national organization was to change their policy around the nutrient content of the foods they were to distribute, the food bank is also able to solicit donations and make food purchases on their own. And the food pantry is able to do that. And then, of course, clients in most settings can choose the food that they pick up from their food pantry. So the Fresh Foods Project seeks to support the development and implementation of strategies that improve the nutrition of foods that move through the charitable feeding network, with a particular focus on nutrition policies. And the first project that we undertook in this space was to interview executive directors of purposefully chosen executive directors across the country to understand the range of perspectives and opinions around the distribution of a healthier product mix. And what we found was very different from what we found when we conducted these interviews 5 or 10 years ago, which is that there is broad scale but not universal support for providing healthier foods. And this comes from a real recognition of the importance of healthy food broadly and the role of the food bank and the food pantry in helping clients to be healthy. Whereas in previous discussions with executive directors, produce was seen as a scarce commodity. There isn't enough for every food bank in the country to distribute produce. We know that this has changed now, and it's no longer viewed as a scarce commodity. Rather, the perception is that geographic and economic disparities in where healthy foods can be accessed are the primary problem. So, for example, it may be much simpler for a food bank in California to access produce than it is a food bank in another part of the country. There's concerns, however, that the food bank is a bottleneck, that even if the food bank were able to get a much healthier product mix, that the agencies, the food pantries, and the meal programs have to then accept that food, and that there may not be adequate demand for it. And then there's significant concern about infrastructure, and this is why we concentrate a lot of our efforts on perishable produce, because this is where the infrastructure concerns are the greatest. In low availability areas, the concerns are really around how are we going to transport the food to my community, where are we going to source it from that we can do that transportation quickly enough. And then in high availability areas like California and Florida, where there might be plenty of nutritious foods available, how are we going to handle it and distribute it quickly enough? The second project that we're engaging in as part of this, this PRC-funded project is called the Fresh Food Survey. Historically, food bank impact has been measured entirely by the pounds of food distributed. The challenges with this metric of pounds of food is that healthy foods weigh less, and we're not able to understand the impact of the foods we distribute on dietary intake. So let me start with the first one, healthy foods weigh less. We know that it's very easy for food banks to quantify how much they do by just measuring the weight of the pallets that they send out on a truck. But if they were to substitute one pallet of, let's say, canned beans with one pallet of lettuce, they would get much less credit for that distribution. And so there's a disincentive there to distribution of healthy foods. There was also no understanding of the impact of the work the food bank did on dietary intake, both because measuring dietary intake is really challenging, but also because there wasn't a lot of demand to measure dietary intake in this setting. That has changed though, and there now is abundant interest in measuring dietary intake. This is because there is interest in understanding which intervention going on in the food bank and food pantry setting is the most effective and which are the most cost effective. There is, as I said before, an increasing understanding of the public health importance of the food we distribute. And there's also a lot more emphasis on food waste and a recognition that the Feeding America network could potentially take in a lot more food from the food system, but if they can't distribute it to the people who need it quickly enough, then collecting that food doesn't help people. It just raises our cost to transport it. And so we have to understand when, where, and under what circumstances the cost of transporting nutritious food is worth it. So the Fresh Food Survey is being developed as a dietary assessment tool that's optimized for the pantry population. And our goal is to provide a ready-to-use tool that food banks can essentially check out to assess the impact of PSC changes at the local and the national levels. And then the national organization can provide data back to the food bank on the potential impact of the work that they're doing. We started to develop this survey using the FLASHY survey, which is a new dietary assessment measure funded by the National Cancer Institute, part of the NIH. This FLASHY survey was targeted towards adolescents and as such included a lot of new foods like ramen and frozen pizza and sugar-sweetened beverages that are also really prevalent in low-income population dietary intake, so it was important for us to include, and also assumed limited numeracy and literacy skills, so it was well targeted to a pantry population as well. We knew that there were already some cognitive interviews that had been done in low-income populations, and then it was a relatively brief survey. And the way that we adapted this FLASHY survey for fresh foods was to implement some changes that would recognize things that are commonly picked up at the food pantry that we wanted to understand. For example, consumption of shelf-stable milk or consumption of canned meat, which are not frequently purchased items, but maybe frequently obtained items from the food pantry. And then we added additional items that we thought food banks would be particularly interested in understanding, like satisfaction with the pantry, food insecurity, use of federal nutrition programs like SNAP and WIC, etc. And then we used multiple rounds of cognitive interviews with pantry clients to understand and improve the questions. We then put out an RFP for a competitive application process throughout the Feeding America network to choose 3 food banks that would do 2 things. First, administer the survey to their clients just a single time so that we could understand the survey properties and how we could improve the scoring algorithm for the survey, and then to pilot the testing of the impact of an intervention or a policy by administering the survey twice, once before a pantry client was exposed to an intervention and once after. About 10% of food banks in the network applied, which shows really robust interest in this type of work, and 1422 grantees, which is a specific CDC grant mechanism, were given priority in the scoring system. We then chose 3 food banks, 2 of which were 1422 grantees, Feeding San Diego, and their intervention is working as is accrediting agencies or food pantries as nutrition pantries if they meet certain nutrition criteria or essentially adhere to a nutrition policy. The Food Bank of Western New York, which is implementing a Just Say Yes to Fruits and Vegetables Behavioral Economics redesign of the pantry, and the Atlanta Community Food Bank, which is implementing a traditional nutrition education program in a new food pantry. As an aside, Feeding America recognizes a nudge intervention in what they call choice pantries as changing the food pantry environment by putting signs on shopping carts and baskets, putting recipes near healthy foods, organizing very attractive and full displays of fruits and vegetables and other healthy food products, displaying healthy products first at eye level and at multiple locations, and then showing lower quantities of unhealthy foods at one time. This work that we've been doing feeds into the work to establish nutrition policies at the level of the food bank. There's lots of heterogeneity among the more than 200 food banks in the network in whether nutrition policies exist. And it's a very challenging topic for many because it is perceived as a threat to food donors and potentially to board members when they start to request only certain foods. Remember, the vast majority of foods are coming in only through donations. We know that specific policies like turn-down policies reduce pounds distributed. Again, that's the food bank's traditional measure of success. We know that some food banks can't purchase any food to fill in the gaps that occur if food donations are reduced. And we know that many food banks take into primary consideration their mission to end hunger, which would mean that the obligation to distribute any calorie, not just healthy, nutritious calories. So the preference historically has been for slowly changing their distribution mix in that would naturally occur as food manufacturers change the healthfulness of their own products rather than creating a formal policy. There are ways like this online course on developing a food bank nutrition policy that helps to really support food banks who want to do this work. Our investment here at the level of the national organization has been to start measuring healthy food distribution, for example, by counting variety as well as pounds distributed, and by supporting food bank collaborations with the healthcare sector, which creates external pressure on the food banks to distribute healthier product because the healthcare sector is generally willing only to distribute a healthier product to people who are coming through their doors. They're also investing in this work by creating regional mixing hubs, which create opportunities in regional levels to source fresh and nutritious food and to distribute it across smaller regions that can accommodate perishability limits. The working nutrition policy for Feeding America right now is centered on the recognition that they have an opportunity and a responsibility to contribute to conditions for people to grow and live healthier lives, and the recognition that nutritious food is the foundation for a healthy body and mind. So we have come a long way in the last 2 years of supporting the implementation of policies that will support the distribution of healthier foods. The conversations across the network are less charged, and the need to wrestle with these questions of policy is widely appreciated, but we have a long way to go. These are the opportunities I see for local health departments to collaborate with the charitable feeding system. First of all, clients can be screened in many settings for food insecurity, and this 2-item screen, the Hunger Vital Sign, is the preferred screening tool across all settings. It's just 2 items to screen somebody for food insecurity. People who are food insecure can be referred to local resources, including the food pantries, but also to federal nutrition programs. Local health departments have also in many cases partnered with their food banks on local and state level initiatives that reduce food insecurity. And I want to let you know that many food banks now have personnel that are dedicated entirely to policy and advocacy work in their community around policy systems and environmental approaches to reduce food insecurity and improve nutrition for low-income populations. Local health departments in many cases also provide on-site services for food insecure clients. For example, food pantries that are co-located at sites offering other services like a homeless drop-in site or a Department of Public Health federally qualified health center. And finally, community coalitions to address food insecurity often but don't always include food banks, and they can offer unique perspectives. I urge you to also check out the Hunger and Health website that Feeding America has recently put up that talks about the connections between hunger and health more clearly. And I offer you 2 additional resources to check out if you're more interested in this area. One is Food Banks as Partners in Health Promotion put out by the Harvard Center for Health Law and Policy Innovation. And the other is Making Food Systems Part of Your Community Health Needs Assessment, which was a collaboration between the CDC Foundation, the Public Health Institute, and NOPRIN. Thank you.
Hi, thank you so much for your presentation, Dr. Solomon. So I have a couple of questions. What type of strategies did you use to target food bank CEOs in order to gain their interest in using fresh produce in their food bank?
We chose specifically certain executive directors based on specific qualities of their region. So for example, how much money they had for purchasing produce, whether they lived in a geographic area that they could solicit donations from local farms, etc. And basically had universal agreement to participate in the study from the people that we reached out to. There is, because of this recognition that food banks really need to be part of the solution to a food systems problem and don't want to be seen as part of the food systems problem, I think there was pretty widespread willingness to participate in these interviews. The problem in a few places was more that there was turnover in the ED staff.
Great, thank you so much. Just a few more questions. Why did you choose to target adolescents for the FLASH-E survey?
The FLASH-E survey was not developed by me. It was developed by the National Cancer Institute, and my understanding is that that survey was developed because of a specific need to improve dietary intake and the dietary intake assessment in the adolescent population. But on reviewing the properties of that study, it looked like a unique opportunity for us not to have to start from scratch in developing an assessment measure for the pantry setting.
Great, just one quick question, and this is for everyone. How are you educating the community on health equity regarding access to healthy foods?
Well, the food bank is, in many locations, really does take health equity perspective on access to healthy foods and has been in the center of a lot of local education. I think that the SNAP Ed programs do a lot of this as well. I'm wondering if perhaps Dr. Friedman has some other thoughts about that.
Yeah, I think that's a really good question. One of the things in the PSE Readies that you could be scored on is your understanding of the problem of, say obesity or poor nutrition, and if, really moving toward more of a social determinants understanding of the problem, which would then lead to policy system, environmental level interventions. And there are some really good resources online, to help begin the process of, trying to unpack more of the health equity issues around food access and healthy diet.
Okay, great. Thank you so much. Thank you all participants for joining us today, and take a moment to fill out the evaluation at the conclusion of the webinar. Thank you, and enjoy the rest of your day.